Alpha-Mannosidosis, it's a rare lysosomal storage disease with an autosomal recessive pattern of inheritance. It's caused by a defect in MAN2B1 gene, which leads to alpha-mannosidase deficiency. Deficiency of this enzyme affects degradation of glycoproteins and causes progressive accumulation of mannose-rich oligosaccharides in various tissues and organs, resulting in impaired cellular function and leads to apoptosis. The prevalence of alpha-mannosidosis is estimated as 1 to 500,000 worldwide. Three clinical subtypes of alpha-mannosidosis have been previously described. Type 1, which is a mild form, type 2, moderate or intermediate, and type 3, which is severe form. However, it's difficult to distinguish between these subtypes because patients often present with overlapping clinical manifestations, overlapping symptoms. Hearing impairment and speech delay are hallmark symptoms in severe and moderate forms, whereas motor impairment and psychiatric symptoms are typical for mild form. And recent literature suggests that symptoms and disease progression are more likely exist as a continuum. Alpha-mannosidosis is a highly heterogeneous condition and is characterized by a broad spectrum of clinical manifestations. Core features of untreated individuals generally include early childhood onset non-progressive hearing loss, frequent infections due to immunodeficiency, developmental delay, intellectual disability, but also musculoskeletal symptoms such as low muscle tone, ataxia, spastic paraplegia, psychiatric findings which are more likely related to secondary mitochondrial dysfunction and cell metabolism. In terms of bone disease, the symptoms range from asymptomatic osteopenia to focal lytic and sclerotic lesions and osteonecrosis. Among gastrointestinal dysfunctions, patients often report diarrhea, swallowing issues, aspiration, but also enlarged liver and spleen. Poor growth has been described as a feature, mainly in childhood. In terms of ophthalmic presentations, patients may present with optic nerve atrophy, retinal detachment, tapered or retinal degeneration. Cardiac manifestations may be more pronounced in adult patients, as are pulmonary issues, including parenchymal lung disease. This figure presents a patient-level view of occurrence of first symptoms, and it shows that the majority of patients first experience multi-system symptoms development within the first decade of life. However, more attenuated, milder cases were more likely to experience the first cognitive, mobility, or musculoskeletal symptoms in the subsequent decades. Notably, first musculoskeletal symptoms appeared to occur closest to the diagnosis in most attenuated cases. Non-attenuated patients, on the other hand, experienced most, if not all, first symptoms such as hearing, cognitive impairment, mobility, musculoskeletal symptoms, infections in the first decade of life.
Well, I'd like to thank Dr. Stepien for her beautiful overview of alpha-mannosidosis and invite Dr. John Wolfe to speak about current approaches to treatment, specifically treating the whole brain in large animal homologs of alpha-mannosidosis. Welcome, Dr. Wolfe, and thank you for participating.
Thank you. Well, it's a pleasure to be back here since 1988, Chet. Could I have the first slide? Next slide, please. So I'm going to talk a bit about the brain. We work with a cat model, which has a severe disease. It's got a deletion mutation and equivalent of the severe disease that was just described. you can read most of this. Neurogenetic diseases, it really affect many genetic diseases. Of course, there are now 8 or 10,000 individual genetic diseases, and about 20% of those affecting the brain are lysosomal storage diseases. So the other, I think you mostly know, accumulation of undegraded substrate, and the mechanism of treatment is cross-correction, that is secretion and uptake by other cells. So it's the major neurologic defect and cognitive deficiency is an unmet need, because while ERT is is being treated in patients, including at CHOP, there is they are not responding in brain. I'd be very looking forward to other people's assessment of ERT for mannosidosis. Next slide, please. Next slide. Okay. So there are basically 4 ways we think about getting genes into the brain. The upper left is multiple injections. That really has not it's gone by. Essentially, it does too much peripheral ancillary damage to the brain. You can go into the CSF, or you can go into vascularly with certain, this is a gene therapy now with AAV vectors. You can go in with specific serotypes of AAV that cross the blood-brain barrier. They do it to various degrees. Next slide, please. And I'm going to focus today on the CSF delivered. Now, we do this through the cisterna magna in the cat because it's easy to do. Neurosurgeons now, there's a method you can go in through the lumbar and feed a flexible catheter up to the cisterna magna. When you do that and inject, you get pretty widespread transduction, this is transduction in a cat brain. One of the important reasons for using the cat brain is, first of all, the knockout mouse has relatively little disease. You have to look to find it, and it doesn't have overt disease. The cat has real disease, mannosidosis. Next slide, please. There are a number of clinical measures that we've looked at, and including these are at different doses. So this is dose per brain. And we then if you scale that up to a human-sized brain, it's going to take an extremely large dose to treat a person this way. But there's enzyme can be found in various kind of markers that Chet talked about. Enzyme can be found in the CSF and in the serum, and it can extend lifespan. So the cat has a very severe disease. They never live past 6 months of age. And the mean in our colony is they die at about 17 to 20 weeks of age. So we can extend that quite a bit, but it is not a normal cat life. This is just treating the brain. This is not treating the rest of the body, okay? And they have clinical neurologic improvements, which we can measure, whole body tremor, ataxia, and balance, and we can quantify these, and some of those are also improved. Next slide, please. We also can, so those are clinical measures in the live animal that's been treated. One of the important things we have is because we have a breeding colony that produce the disease, just like in the mice, that we can directly compare age-matched normals, untreated, and treated. And that gives a lot of power to evaluating the effects of treatment. And this is one example on, this is a magnetic resonance spectroscopy. It's a specific type of MRI measurement that measures gray matter. And what I want you to look at, I don't have a pointer, but the yellow boxes show OS. That's oligosaccharides. That's the peak in this spectrum. And so this is an MRI, just may or may not have had them, but you've heard of them. The second one is affected, and you can see the level of the OS peak there is much higher. And then the third one, the treated, the peak is way down. And these can be quantified, and we have shown that they go back to normal levels at a high enough dose. Okay, next slide. This just shows an example of the histopathology, different regions of the brain going across the top. And I don't expect you to digest all the details. The thing to focus on is the top row is normal, the next row is untreated, and all the white open spaces basically are empty, distended lysosomes that you're seeing there. So that's what you measure. And if you go down, so at, I believe it's 2.5, 10E13 dose, goes up 5E13, then to 1E14, you can see that those patterns are much more similar to the normal than they are to the abnormal. So we can reverse the disease. And this is generally about a year of age when these are done. We let them live as long as they will. Obviously, we have humane criteria for deciding when to terminate the animal. Next slide, please. And then in white matter, again, now here the different structures are down the right side and the doses are across the top. And you can see there's a difference, but this is a stain called Luxol Fast Blue that you cannot quantify, okay? But these can be quantified by a second MR method called diffusion tensor imaging, which focuses on white matter. We do these in the same session with radiologists, and that shows that they can be normalized. Okay, now are they completely normal? That's kind of an open question, but it's vastly improved, and the animals live longer. Next slide, please. All right. And this hasn't been published yet. It's coming out sometime in the near future. Is if we look at progressive age, I told you that the cats die. They never live past 6 months, and they typically die at around 5 months, 20 weeks or so. When we treat at different ages, so the previous slide showed the animal treated at 6 weeks, which is post-symptomatic, okay? So it's already started to show symptoms at 5 weeks of age, and then it gets progressively worse, just like the human disease does. And if you go, initiate treatment at different ages, the top row is normal, the second row is untreated, and then it's at 3 weeks and you get a lot of correction. 6 weeks, you get a lot of correction. And then there's less at 9 weeks and 12 weeks. We can't really treat them past about 12 weeks because they're in such a fragile state that anesthetizing them to do the injections and so on becomes very difficult for the patient, as it were. Next slide, please. And similar kinds of results in the Luxol Fast Blue. And these correlate completely with what we see in the MR spectroscopy and the MR diffusion tensor imaging studies, which quantify the amount. Next slide, please. And this is unpublished data. I'm working with a physiologist who does electrophysiology of the cat brain. The cat was a very important study in determining connectivity initially in the visual system. And for many decades, the rat, the cat, and the monkey were the major neuroscience models. Okay, these were all normals. And there now are very few people who know how to do these experiments. And this is only in one pathway. It's a limited study. It's preliminary data. But if you look at the pattern of all these curves are discharges of electrophysiology from a stimulus and then reading. And that's a sort of classic electrophysiology method to use. And the top is the normal, and you can see it has a pattern of dipping down and then recovering is what it's doing, the electrophysiologic impulses. And the second one then is an untreated animal, and you can see it's very different. It's chaotic, it's variable. A normal cat brain is actually very reproducible from one animal to another. These have more variability. And then thanks, Bob. Okay, that's, you can see how disorganized that looks. And these are other types of analyses of the data, the normal, very chaotic. And then when you look at the treated, it is not normal, But notice that the pattern of electrical discharge and recovery is more similar to the normal animal than to the diseased animal. So we believe, and these are treated post-symptomatically, so we believe there is some recovery of function here. There's a lot more work that needs to be done on this. Next slide, please. I think that's a acknowledgements, yeah, summary. A lot more work to be done on this. We have to look at other pathways, but there are multiple pathways that are important. There are issues like the length of the pathway to be able to detect subtle differences in myelination of the white matter part of the brain, which can affect the electrical transmission. We have no idea because we don't have the equivalent of cognitive tests in the cat that you would in humans, but I think it suggests that we may, by treating the brain, be able to recover some function or maybe prevent further degeneration of function, which would be probably clinically equally important. So this is a summary. Where are we with time? Probably quick. I don't think I need to run through all of them, but the next slide, that summary, that'll be in the deal. And then the people who do the work, my lab, Jackie and Pavan, Say Young and Era are research associates, postdoc, former postdocs, and so on. At Penn Vet, we have fantastic veterinary nurses who take care of these animals, who are absolutely vital to the success of the program. Charles Viet actually did his PhD thesis in my lab on the Mannosidosis model, and then went on to study other lysosomal storage diseases. He's a neurologist. And then Penn Medicine, the imaging stuff is done with colleagues from the Department of Radiology, and Diego Contreras in neuroscience is the electrophysiologist. And of course, we could not do this without NIH funding. So write NIH or write your congressmen and senators and ask for more support. I think that's the last one. Next slide. I think, is that the last one? Yeah. Okay. Thank you.
Well, Dr. Wolf actually came in a couple of minutes ahead of time. So we do have time for questions. Let me just lead off with one. I was very interested looking at the neurophysiology. Do you think that likely correlates with remyelination and repair of the white matter, given that that dispersal of signal looks very much like what you see in the peripheral nervous system with demyelination?
Probably, but we don't have that data. And we also don't have, that's only one pathway in the visual pathway, which is a relatively short one. It's so well established in feline electrophysiology. That was the best place to start. But our proposal, which is in for review now, is to do that in many other pathways we know, because there's the whole brain is affected. There's pathology everywhere.
Thank you very much.
John, that was wonderful work, all in the brain, which is the hardest place to go. Does it matter what happens in the rest of the body? Do cranial nerves matter, like in auditory nerve? How about other aspects of the condition in the cat?
Yeah, we do. That's correct. And one of the things that that I think can be combined, if you project this to human, is you now have ERT that doesn't treat the brain disease. And I think this could be done in combination with that. Now, I think in the long run, you want gene therapy for both the body and the brain that works. These studies, this applies actually both to the doing in the CSF, you get relatively little correction of other organs you might expect. You can find some fragments of genomes of vectors outside, but they're not producing much enzyme. The other going in with the most efficient blood-brain barrier crossing vector, you get a little bit more, but at most it's about 10% of activity in the serum, for example. We probably need to boost that up, which is what we're proposing to try to do now. But I think it could be used in combination with ERT. Now, you'd still have the problems of weekly injections of ERT and so on, which is burdensome. And so whether you can shift patients from that to a gene therapy protocol for the non-CNS portions, it might be two different serotypes that need, and that's going to be a fight, I suspect, with FDA to get them to approve that. But since ERT is approved, adding a gene therapy component to it may be effective. I don't run clinical trials, but it's translational.
Thank you, John and Chet. Any other questions at this point? Well, great. Well, thank you for those. I think at this point we might move ahead. Delighted to ask Robert Saho, I hope I'm pronouncing your name correctly, Robert, from the Charles University in Prague, to speak on options for therapy in alpha-mannosidosis. Robert, thank you for coming all this way, and thank you for speaking.
And if I could just ask all of our speakers throughout the day to speak very closely into the mic. We have our microphones, the speakers turned up as loud as the hotel can make them, but some of our audience members are still having a hard time hearing. So just make sure you're very close to the speaker. Thank you.
Thank you so much, and thank you for the invitation. So I'm very happy to be here and talk about the options of therapy in alpha-mannosidosis. Can I ask just for the slides, please? It will be better like this. So when I looked into the literature, we can see that there were so far 30 patients published who underwent the transplantation, the first case being in 1987, as I can see, or yes, 87. Unfortunately, this patient died 18 weeks post-transplantation because of sepsis, graft versus host disease, and bronchopneumonia. When you look at the numbers, you can see those were small case studies. The biggest study being published by Minarek and colleagues in 2012, having 17 patients included. According to the literature, transplantation can reduce mannose-rich oligosaccharides. It can normalize hepatosplenomegaly. It can reduce the number of infections and improve or stabilize cognition, also hearing. And there are cases where there was stabilization or only slight progression of dysostosis multiplex. However, we need to think about that the outcomes are dependent on the age at the transplantation. We were really curious what are the outcomes of patients who underwent the transplantation after 2010, which was the year until when Minarek and colleagues collected data. So we decided to do a retrospective data collection and include patients with enzymatically and/or genetically confirmed diagnosis of alpha-MAN. At the end, we collected data from 21 children with alpha-MAN. All except one had genetically confirmed diagnosis of alpha-mannosidosis, and all with available data had reduced or lacking mannosidase activity and pathological urinary oligosaccharides. The patients were coming from 14 centers and 11 countries. This is just to show you which were the participating countries, and here I would really like to thank all co-authors who helped with the study. We were also interested in the first symptoms leading to the diagnosis, and in more than half of the cases it was developmental delay. In less than half, it was recurrent respiratory tract infections, facial dysmorphia, hearing loss, and hernias. We were comparing our data with the study of Minarek and colleagues. So as you can see, the median age at transplantation was almost similar. We had a bit better age-alike compatibility. When it comes to stem cell donor and stem cell source, there were no big differences. However, the conditioning regimen changed quite a lot, and we were also publishing data on graft versus host prophylaxis, which Minarek and colleagues haven't done. When it comes to the complications of the transplantation, you can see that we had bit lower or less follow-up period, 2.3 years. However, when it comes to the overall survival rate, it's 100% versus 88. Two patients died in the study of Minareg and colleagues. Those patients died in the first 20 weeks after the transplantation. So probably we would see that. And it's also nice to see that the rate of chronic graft versus host disease was also a lot less, 5 versus 35%. This is just to show you one more time that no patient died in our cohort, and there was only one patient who had chronic graft versus host disease. When it comes to somatic outcomes, which you are probably more interested in, there was quite nice improvement of hearing, also recurrent infections, also the facial dysmorphism. However, this is quite a subjective matter, but hepatomegaly had almost the best improvement, and you can see the others as well, which we had only low numbers, so it's really hard to comment on those. We also looked at the laboratory outcomes. When it comes to urinary oligosaccharides, it fully normalized in 4 of the patients with available data, and in 6, it was not fully normalized after the transplantation. With the enzyme activity in 16 out of 18, it was normal. In 1, it improved, but still wasn't normal. And in 1, after the transplantation, it was still low. Can I ask for the next slide? It looks like it's not working again. Some of the centers were also giving concomitant enzyme replacement therapy to the patients before and after the transplantation. You can see the average doses. However, we cannot give no clear evidence-based recommendation on this. However, we assume positive effect can be assumed from this, and the length of the post-transplantation treatment is originally distracted from the experience with MPS I, and we consider it is reasonable to continue the therapy with ERT until we have normal enzyme activity. Next slide, please. What is very important are the neurodevelopmental outcomes. In the literature, the biggest study by Minareg and colleagues showed that all 17 patients in their study had below average skills for their age groups. And after the transplant, all patients made developmental progress. However, none of the children was able to attend regular school without special education. Next slide, please. In our study, probably Julie Isengard will talk more about this, but when we looked at the patients before the transplantation, 4 patients had development in the average normal range, 13 patients had mild neurodevelopmental deficit, and 1 patient had severe developmental delay. When we move forward after the transplantation, 16 patients had data. However, 3 needed to be excluded because of the short interval between transplantation and evaluation. And 11 patients had improvement or at least stabilization of development, but still a slight delay persisted. And 2 patients had normal development after the transplantation, one of those still needing special education. Next slide, please. And the other option is ERT. As I said in the beginning of the presentation, the ERT is with well-managed alpha or LAMZD, given once every week. Here you can see the effect of ERT. So it reduces oligosaccharide concentrations. It increases IgG concentration, so it reduces the number of infections. It improves motor function, pulmonary function, also quality of life. However, there's almost no improvement of neurological manifestation, and we must say that in clinical trials, the response rate was very high in more than 85% of the patients. Next slide, please. These are the clinical trials in which the efficacy of ERT was showed. Please, next slide. Here I highlighted that the decrease of serum oligosaccharide concentrations was showed in both studies, which I have on these slides. On the left side, it's the study which included also adults and pediatric patients. On the other side, only the pediatric patients, and on the left side, it's placebo versus ERT. Next slide, please. This is the same just on motor function. So this is how the 3-minute stair climb test looked in the 2 studies I mentioned before. Next slide, please. This is what I wanted to show you as the last thing when it comes to ERT, the Global Treatment Response Model, which was published by Harmatz and colleagues. They found those 3 domains, pharmacodynamics, functional, and quality of life, and set those endpoints. And when we move to the next slide, they did a multi-responder analysis on long-term ERT, and they in their study they are saying that global responder is a patient who responded in at least 2 domains. So if you look at the graph when it comes to the pediatric population, it's 100% when it's at least 2 domains, and in adults it's more than 88%. Please, next slide. However, ERT has also some limitations or side effects, the same as transplantation. Unfortunately, there's no passage via the blood-brain barrier, which was already mentioned here. No effects so far on several manifestations of Alpha-Man. There can be potential development of anti-drug antibodies and may be associated with infusion-related reactions. Next slide, please. So to conclude, both transplantation and ERT in Alpha-Man have or has their pros and cons, and the treatment decision is individual and should be multidisciplinary. We also have in Czech Republic patients who were offered transplantation, but they decided not to move forward and just stay on ERT. But in our opinion, transplantation should be considered in all young children with preserved mental potential, with parental fully information of both options of the therapy. And with the next slide, I would like to thank you for your attention, and I'm happy to take questions in the Q&A session.
Thank you very much, Dr. Saho. You stayed exactly on time, gave a beautiful presentation. Do we have any? We have a couple of minutes if there are any questions from the audience or online. Very good. So if I understand correctly at the moment, your recommendation is if you have a treatment-naive patient, particularly a young child, you would offer hematopoietic stem cell transplantation as the first option. The rationale being that in contrast to enzyme replacement therapy, this offers the prospect of some degree of neuronal salvage, if not complete preservation, whereas the data you've presented shows that although enzyme replacement therapy is relatively effective for the somatic manifestations, it really doesn't have an effect on neurological manifestations.
Exactly. This is what we are doing. So when we have a new patient with Alpha-Man, especially pediatric one, we offer both options. We tell the patients the pros and cons. We try not to influence the parents, but I would recommend the transplantation for the pediatric patients, especially with concomitant ERT, as shown on one of the slides.
Thank you. All right. Yes, we have a question. Do we have a microphone? Or if you'd like to step, yeah, we have a microphone at the front too.
Matthias Schmidt from JCR Pharmaceuticals. Wonderful presentation. Is there a situation where you would recommend to the parents and the patient post-transplantation to get on ERT?
I have no like experience personal with this one, but I have heard from the US colleagues that they have patients who are long time after transplantation, and they were put on ERT with quite nice effect, especially on motor function. So I would consider this option, but have no personal experience so far on this. And the other thing is the reimbursement. In Europe, it would be quite hard to make the insurance company pay for the ERT after transplantation. So it would be interesting to see what would be their answer.
Thank you very much. Well, if there are no further questions, we'll move on to our next presentation. And that will be from Sarah Forsman, who will provide the patient perspective on alpha-mannosidosis. Thank you.
Hi guys, how's everyone doing this morning? Good? You're good? We're alive? Hi, so my name is Sarah, and I was born with alpha-mannosidosis, and today I'm honestly just going to take you through the experience that I had. Excuse me for my voice. I am overcoming a cold right now, which is great. But I'm able to speak, so this is better than how my voice was a few days ago. Is it? Okay, thank you. Awesome. So this is really just a simple slide of the journey that I've been through. So I was born in 1999. I'm currently 26. And really, like, from the start, I had symptoms of alpha-mannosidosis appearing. But I didn't get diagnosed until 2002, which was when I was 3.5. So I had all of these symptoms appearing. I had 20 different doctors because no one knew what was actually going on. They all thought it was 20 different things, but it was just one thing. So before diagnosis, I actually had a skull reconstructive surgery because the bones just in my skull were not growing properly, which is actually something that is found typically with Alpha-Man. So typically the forehead will be like taller, I guess that is. But yeah, so I went through that surgery and they literally reconstructed my whole entire skull when I was 1.5 years. But then diagnosed in 2002, and I had sugars in my urine, ataxia. I was hearing impaired. I had hearing aids, seizures, sleep apnea. There's so many things. And then just I had so many challenges with my brain as well. And then so when I was diagnosed, my parents were given honestly 2 options: for me to go through a bone marrow transplant or to do nothing. And at the time, there was no enzyme replacement therapy. So it's great to see that we've gotten there today. And it's fantastic seeing the medical advances, but we only had a bone marrow transplant as a potential treatment. And even when I went through the transplant, it was considered experimental. I was the 13th person in the world with Alpha-Man to go through this transplant. So there was a lot of unknowns going into it, and luckily it worked. And I'm standing here before you today because of that transplant, being able to talk to each and every one of you in this room. And yeah, like it was a journey. And once I was transplanted, the journey didn't stop, because after transplant, my parents had me involved with so many different therapies. I went to physical therapy, occupational therapy, equine therapy, speech therapy. I then later did neurofeedback, which is for the brain. And then eventually we found a functional neurologist. And so I'm just going to back it up a little bit. So when the whole COVID thing happened in 2020, my brain could not comprehend what was going on in the world. So basically when COVID happened, like I went into this whole entire, what I like to call my drunk phase, because it literally felt like I was drunk. My brain was basically malfunctioning, and I would sway. I had balance issues. I had a lot of headaches. I had so many challenges. Like if you saw me, you would have thought I was drunk. But it was in 2020 where I had a dream, and I'm Christian, so I believe in the Lord and Jesus. But I had this dream, and I saw myself die, where I was literally in a wheelchair. Like I had never been treated for alpha-mannosidosis. And so I saw myself die, but then I saw myself come back to life. But when I came back to life, I didn't have any challenges. So I had this dream in 2020, and I was believing that I was going to be completely healed from all of the brain challenges that I had. It was a few years later when I stumbled upon a doctor, and he was a functional neurologist, and he understood how the brain is wired and all of that. And he helped my brain, both hemispheres of the brain, to be more equal, because my right hemisphere was lacking. I was more left-sided, but he was able to make them equal. And all of the challenges that I was experiencing, they went away. And a lot of times in just what I've experienced in this alpha-mannosidosis community, the brain is one of the biggest challenges, because just what alpha-mannosidosis does to the brain. But once you have the transplant stops it from progressing. And then it's, oh, we have to rewire the brain because the brain wasn't wired properly. And this is just, I'm not a doctor or anything. This is just from my personal experiences. But now it is 2023. Well, no, it's not 2023. I need to know what year it is. I gotta know what day it is, first of all. But 2025, don't know how we got here. But I've experienced this healing since 2023, and I recently just graduated from college. I have a bachelor's in marketing now. I do the communications for ISMRD, so any emails that you guys see or social media, I've done that. So, and then I have a podcast, and I do all of these things because I've been given a life where there's some people like who haven't been given a life. And so my desire is to do as much as I can because I've been given that life. And so I love the rare disease space. I love alpha-mannosidosis, but I also love all of the other rare diseases. And I'm so grateful to be able to just be here speaking in front of you guys right now, because this journey, it's been a challenging one. It has not been a journey where it was one and done. It was not a snap of a finger. I wish it was a snap of a finger, but it wasn't. And even in my life right now, ever since I was younger, I didn't say this earlier, but I had a knee challenge, and I've always had it. And so I've been talking with a friend, and now I'm standing here and I don't have the knee challenge anymore because he was able to figure out what was actually going on with my knee. It's a floating patella, and so it's really just lack of muscle around my knee. Um, and yeah, like I'm literally seeing the things with my body be healed as well in this season. So yeah, like it's a beautiful time, and I'm going to now go into the um the survey. Oh, I forgot I had that slide. It's okay. Okay, cool. Thanks, Abby. Yeah, so just a few things. Diagnosis is not the end of the journey, it's the beginning. Awesome. Thank you, Abby. You're the best. Um, so as we can see, there's lots of different things on this pie graph for most common symptoms, but the largest one is the neurological decline that occurs with Alpha-Man. I'm ready. Thank you. What?
Sarah, thank you for that wonderful upbeat talk. It's very inspirational for all of us. I wondered
Do you
if I
have
could ask you.
comments on the survey?
Yeah.
A little.
A little more. I think there's a couple more slides for the survey.
Okay. We'll hold the questions then.
Yeah, so for the next one, desire for improvement. Oh, sorry. Trying to speak into the mic. So desire for improvement, once again, the largest one is neurological decline. All right. And now the burden of disease. So the burden on patients, caregivers, and siblings, the largest is the emotional impact. And then for barriers, it's really the lack of medical expertise and access to a specialist. All right, now I'm done. Thank you.
Well, thank you again, Sarah. Please, this is open. We have a few minutes for questions, but let me ask one, and then I'll hand over to Dr. Wolf. You did emphasize the fact that it's not one and done therapy, that there is an ongoing process. And I was interested, I wondered if you noticed that during the pandemic, when you experienced these new symptoms, was that in the context of not having access to your therapies? Did you notice a relationship there? It's something many of us observed during the pandemic because our patients couldn't get their regular therapy. Was that something that occurred to you as well?
There was really just one. I was going for the neurofeedback at that time, but I don't think it was just because of like not going to that one therapy, because that was the only therapy I was going to. For all of my life, I had challenges with change, to the point of like if one little thing changed in my schedule, I just would have a meltdown. So having a completely big change with how we lived life and everything like that, I think that just had a very major impact on just how I was able to function, because I wasn't able to function with that big of an impact.
Sure.
Mhm.
I don't know you, Sarah, but you seem to me to be a very ebullient social person. Do you do you think that lack of the same social contact might have been an issue as well for you with the onset of the pandemic?
It's very challenging to say. Yeah, I do enjoy being around people and speaking, but also being involved with like friends and all of that has also been very challenging, because of all of like the things that are like going on around, because I've also had a lot of challenges with just the processing speed of like how fast people are talking, if there's a lot of noise around, if there's lights like at a dance or something like that. Yeah.
So it's a mixed bag.
Yeah,
I'm
it
gonna-
really
Thank
is.
you. I'm going to hand over to Dr. Wolf.
If you wouldn't mind sharing, what type of mutation do you have? Do you know, do you have some residual activity prior to the transplant?
Mom.
Mom?
Hello. Let's see, we're going to be celebrating 21 years post-trans, 22 years, 22 years?
I think 22.
I tell you, we don't even know what year it is today. You know, you lose a lot of time during this process. So, you know, it was a long time ago. The information given at the time of diagnosis is changed so much, you know, access to this information even. She was very, she's actually in the normal range. The last time they checked it, and it was probably about 17 years ago, the enzyme activity, because they figured she was stable about 3 years post or after, and haven't checked it since.
So, but you don't know whether mutation is a nonsense or missense, if those terms make sense. Sorry.
Yeah, no, that's right. Way too technical for us. Yeah, and they don't
Okay,
share that
makes
kind of
sense.
information with parents, right? I mean, and when you get a diagnosis, pretty much they tell you, you know, at first they actually had diagnosed her with non-Hodgkin's lymphoma for 6 months, right? And then, oh, you know, they stumbled upon, because of her having another surgery, and had asked them to biopsy cells, right? So she was the only patient at CHOP in Philadelphia for 20 years. So that information was very limited, and what they actually shared with us as parents. So a lot of this, yeah, you know, we find out more as we've gone along, but I don't know those specifics.
Thank you.
Yeah, thank you though. Good question.
Well, again, thank you, Sarah. It was a wonderful presentation. We appreciate it very much. Thank you. I'd like to welcome our next speaker, Dr. Julie Isengart, neuropsychologist who's very experienced in this field, working here at the University of Minnesota. And Julie is going to address the long-term effects in bone marrow transplantation. Thank you, Julie.
Thank you. Sarah, that was beautiful. I feel less equipped to talk about the long-term outcomes than you. Every story is so meaningful, and let's see here. So this is my clicker, right? And maybe it'll work. So just to be clear on neuropsychology, particularly when it comes to rare disease, what we do is we measure function. And there have been origins in evaluating IQ or intellectual function over time. As Sarah described about her lived experience, and certainly as many of you are aware, there's so much more to someone than an IQ. But so why do we have so much about IQ scores, which are sometimes described as developmental quotients or DQs? They're not actually one and the same. We do it because actually IQ can be a pretty good indicator of disease progression. And so it's been that one metric that has been sort of followed over time, but it's pretty incomplete. So let's see if this works. Nope. I'd say next slide, please, but I'm guessing that's what you're trying to do. So I don't have to go too deeply into these pieces, but I really want to make sure to highlight this aspect about the variable disease impacts, because as certainly as many of you appreciate, Sarah has her story, but there are other individuals with alpha-mannosidosis who have very different stories in terms of how how they've been touched by it, how they've been impacted by it, and certainly even if they've been transplanted, in addition to the fact that it's not just a one and done, also there are there's quite a lot of heterogeneity in how the condition affects individuals. The other thing is that even though we talk and so much about the brain and neuropsychologists focus so much on the brain, in rare disease, we also focus very much on how the head to toe effects of the condition interact with brain function to potentially create pictures of, brain issues when in fact it might be another part of the body that's affected. So let's see here. Next slide, please. No, it worked? Oh, okay, yeah, it did work. Okay, terrific. So these have been discussed. I'm going to be focusing on bone marrow transplantation. We do a lot of collaboration at University of Minnesota with the transplant group for examining outcomes of transplant. So, so let's get into really evaluating functional outcomes. Oh my, it's going backward. Oh, sorry. Okay. Well, should I not use the clicker? Oh, okay. Okay. So, a lot of times the literature will describe things like developmental challenges, developmental delays. There isn't actually uniformity in what these terms mean. And so we do the best to try to figure out how exactly is someone with a certain condition impacted. I really have to compliment Dr. Saho and colleagues for their efforts to gather information on the neurodevelopmental functioning of individuals who have gone through transplant for alpha-mannosidosis to try to get a better picture of, in fact, how are things looking when somebody has been treated and how do they look long term? So, the question is really about, the penetrability of the blood-brain barrier and how transplant tends to overcome that, whereas ERT is not expected to at therapeutic levels, and really trying to understand what are the pieces that are based on the brain and what are the functional difficulties that are based on other aspects of the condition. So I want to orient you to how we in neuropsychology think about rare conditions. I believe this is a pointer here. Yes. Okay. So this is just a hypothetical disease. This is not alpha-mannosidosis. But what we often do is we compare people's chronological age to their mental age. Okay, so when there is somebody who is not affected or who is developing in a typical fashion, then their chronological age and their mental age should be roughly the same, and that's what this purple trajectory indicates. We also have this vector of disease effect. So when there is a condition that causes pediatric decline, this is sort of working against development. This dotted area here represents those quiet actions of the disease accumulating and creating injury that nobody else can see or nobody else can really understand. So when Sarah was talking about it took a long time to get diagnosed and developmentally, maybe there were some challenges, but there wasn't anything dramatic to say, hey, we're worried about decline in this child. That's during this invisible time. So, okay, what I've highlighted here is this important point in this hypothetical condition at 4 years old, the vector of disease has started to affect this affected individual's development and started to pull them away from the curve. Now, this is an issue because this child is still acquiring skills. Okay, so nobody is suspicious that there's decline at play. And this is when a lot of individuals are still not diagnosed and they're seen as like, well, they're learning, they're just kind of learning slower, and so it's fine. But then eventually the vector of disease overcomes development and starts pulling the individual downward. So if there's intervention done here when, hopefully the condition has been identified, then there is some more, there's often in many conditions this ability to continue to gain skills. Now you'll see that this one is purposefully not parallel to normal development. And that's because what happens is this intervention here has really come at a time when this person is on a trajectory of kind of a neurodivergent, neurodiverse course where there will be some learning, but maybe just not at the same pace of typical development. What we often don't have a clear answer for is what happens when the disease vector has overcome development and started to create regression, and those outcomes are less clear in terms of what will happen. So when we think of function, we think of all the ways that people function. The communication is really important. Certainly in alpha-mannosidosis, language difficulties are often seen, attention, and then of course, skills for independence. That's one where a lot of times somatic effects of disease can really impact somebody's ability to be independent at the degree that they wish in their day-to-day lives and so forth and so on. When we think about the contributions to function, this is where I was talking about, okay, so the disease is affecting the brain, but also the disease is affecting other aspects. If there is pain, I think any one of us who, may not have alpha-mannosidosis in the room, you can certainly appreciate how difficult it is to concentrate if you're walking around with a migraine. And so we have to appreciate that if somebody with alpha-mannosidosis is carrying an infection or in some sort of pain, they might come across as having cognitive difficulties when really it's the effect of their condition. It's really important to include the community voice when we think about alpha-mannosidosis. This is because there's such heterogeneity, and so one person's story will not necessarily predict another. And like I was saying, there's so much more to an individual than their intellectual function. So, and certainly with a lot of clinical studies now, clinical trials, there's such a regulatory emphasis on reflecting how patients feel and function and what their priorities are. So I'm going to, close this with a description of a study that we're incredibly grateful to ISMRD for funding. This is a study that we have ongoing, and we are looking at the functional outcomes of individuals who have undergone bone marrow transplant for their alpha-mannosidosis. So we're really pleased about this because it's a prospective study. It's planned, and we're gathering data on individuals. We're actually testing them with remote means. And we're very pleased to be doing this in partnership with ISMRD. So I'll walk you through what this study is. Dr. Troy Lund is my co-PI, and he's in the back, and I'm looking forward to his talks today as well. So we'll talk a little bit about the study, but just so you know, in the wonderful work in our collaboration with Dr. Saho and colleagues, we have found, these particular areas of challenge with language and behavior, kind of the executive center of the brain, how the brain manages. And I'm about to get cut off, I'm sorry, but okay, so let me just walk you through the study procedures. It's Zoom-based. We get some background information, and then we actually do neurocognitive assessments. I think Dr. Jarnes and I are going to be talking about what are the outcome measures we should be doing. And we're also very much hoping that people can take the time to refer participants to this study. I believe some announcements are coming or have come out from ISMRD, but we're going to be looking at things beyond IQ, processing, attention, and how various physical aspects of alpha-mannosidosis have impacted individuals and sort of contributed to any gaps that they perceive in their quality of life. So, thank you.
Very much for that overview, Dr. Isengard. It was beautiful and complemented what we heard from Sarah earlier. Are there any questions at this point before we call on Dr. Janis to talk further about outcome measures?
I had a question.
Yes.
Excuse me, I have a question about the schedule because I know that we have a discussion from 10 after to 20 after, and it's currently 7 after. And
Yes.
there's a lot of questions from the audience in the Zoom room.
Right. Let's address them then.
Do you want to start with those questions?
Sure. Yeah.
Great. And maybe if we could pull up some more chairs so Robert and Julie can both be comfortable on the
Yes.
panel, because maybe you'll both want to weigh in. One question is from one of the families, a patient advocate who has a child with alpha-mannosidosis. And she went to 2 different hospitals in 2 different states, one at CoSara Children's in Louisville and the other at Cleveland Clinic. Both advised her not to do BMT and only to do ERT. In our experience, we went to 3 different hospitals, or 4, here at Children's Masonic. We went to Pittsburgh, we went to University of Miami and Duke. They all did tell us to do BMT and not to do ERT. So can you weigh in on the conflicting information to parents?
I will pass this over to my expert colleague since I've retired. I'll make a comment later if necessary.
It's quite a hard question, but as I said during my talk, we try to give all the information to the parents about both options. And as I mentioned, we on the other side have parents who decided not to undergo transplantation because of the negative, negative things connected to the transplantation and graft versus host disease, sepsis, infection rate. So that's why we are doing this. I would for sure tell the parents that I would in like personally opt for the transplantation if I would probably have a child, but it's really hard to think about and to immerse into the role of the parent who needs to decide. But I would say the decision should be made by the parents at the end. We can just give the information we have. That's why we wanted to also do the study, because now at least now we can say that the transplantation is more safe and as it was in the past. So the protocols of the things which are done before and after are better.
And just to follow up that, do you think that it is because there's not enough circulated information on the choices, and that's why the parents are receiving maybe misinformation or not complete information, and that they should just keep going and going to different centers and asking?
Sure. It's very hard to compare patients who are treated with ERT and transplantation, and there's not enough data, I would say, to compare those. Even when we did the study to compare patients from different countries, when it comes, for example, to neurodevelopment, it's very hard because each country is using different methods when it comes to assessing neurodevelopment. So it was very hard, and we are thankful to Julie, who tried to at least compare it somehow.
A quick follow-up question, and I know you can't make a diagnosis from such limited information, but you use the terms young and child for recommendation. Do you have a rough age cutoff at which that decision changes?
That was what we were asked when we went for the publication. The reviewers were asking the same question. We tried to look at the age of 5 years, but the numbers were so low. It was like 8 versus 8 that we cannot say any like conclusion. From the literature, it seems like before 4 or 5, it should be better, but it's very hard to say.
Oh, sorry.
Yeah, I have a question for you, Dr. Eisenkart. Would you be interested in supporting a natural history study for beta-mannosidosis since you have done one for alpha?
Absolutely. I think, oh, Dr. Lund, yes, that would be incredible. Is this working? Okay. Yes, absolutely. I mean, that's, it's so critical. Natural history studies are really important. And so speaking of natural history, we know that there's a lot of heterogeneity in alpha-mannosidosis and the way alpha-mannosidosis affects people. And I will say this as somebody who is not a transplanter, I do find as an outsider looking in that a lot of advice seems to be based on risk of transplant and how much can you tolerate cognitive disability or not. And I just want to say it's like everything in the world, it's just not that simple. And it's not about, are you willing to have a child with a cognitive disability? And if you are, then let's go the safe way with ERT because there's so many fewer risks. What Dr. Saho and colleagues have found is that transplant has really come along and it's safer with less risk. This doesn't mean that I, as a non-qualified person, am recommending it, but to explain why is there this variability in recommendations. I would also say I do wonder to some degree if differences in disease presentation are also impacting. We can't all of a sudden call alpha-mannosidosis this homogeneous condition that absolutely is going to follow a particular course and that course absolutely is adequately treated by ERT or that it is absolutely dire and if you are 8 years old at diagnosis, you've lost your opportunity. I think probably the conflicting recommendations have to do with that. Dr. Lund, you as a transplanter look like you could really add some wonderful comment.
Yeah, I just want to clarify and answer the question. There is no age cutoff. So we don't do anything by age. Younger is always better because you have less side effects, less infectious disease risk, you're more tolerant to chemotherapy, and you usually develop better. So we can't say there's an age cutoff. Could do a transplant at age 5, 6, 18, 21, whatever. The conflicting advice comes from conflicting physicians. That's where it comes from, I think. So if you're asking a geneticist about the risks of transplant, there's no way they're going to have the accurate information or even be favorable in many cases because they don't know about the risks of transplants. I think you need to seek out a transplant center, which explains why you got 3 transplant opinions from 3 transplant centers. I don't know how to get that message across to families that it's a disease that's multimodal, so there are different therapies and there are different specialists, but if they're considering transplant, they shouldn't be asking their neurologist about transplant. They should be finding a qualified transplant center, and that is a center with expertise in the field. I think it's easier to find those today because of the internet. Like you can Google any of these diseases and generally the same excellent centers come up on those lists. But that explains why the advice is so disparate. And then the parents can go home or talk to whoever they want to trust and say, do we want to go this route or this route? Of course, I'm going to advise transplant above all things, basically. I think we do it well and have great protocols and it's advanced a lot, but I'm always going to reserve the right to say, here's a child of a genetic background who has 0 matches. And now I think this transplant's going to be so high risk that they're not going to do well, that maybe Enzyme is the right choice. So I never want to be completely absolute about these things, but that's just kind of my take on it.
I have another question here from the audience. Is there a global registry of these outcomes of BMT and ERT that can be used as an informational resource for parents or doctors to make informed decisions on treatment options?
For ERT, at least in Europe, there's a registry for the patients after the transplant. I'm not aware of it. Like, we were collecting the data retrospectively, and I don't think so that there's an ongoing registry for patients. Maybe this study which you were presenting can then give us some new results.
Dr. Wolf, do you want to weigh in?
Yeah, just wanted to add a comment that with so few total patients, it would be really helpful to have a number on, and again, a registry would do it, of ERT and BMT, and to there may not even be enough patients to stratify it by mutation type and age of treatment initiation and things like that, which would be helpful to know, but given the total number, it may be too small to do that. I don't know.
There's another question about NIH funding, which I think probably affects all our diseases. And I'm not too sure if we're going to be touching upon that formally. We're at 11:18. We're about encroaching on the coffee break, and I'm sure people wouldn't mind to just take a coffee break if they want to, and we can continue the discussion if other people would like to. So how's the NIH affecting our community? Or the lack of funding or changing funding
There's
landscape?
A glimmer of hope in the last few weeks, and the Senate Appropriations Committee passing a 1% increase actually to the budget. It has a dramatic effect, and while there's a recognition.
Hold the microphone a little bit closer.
Sorry.
Can you pull
I'm sorry.
Thank you.
There's been a glimmer of hope in the passage by the Senate Appropriations Committee by a pretty large margin of an increase for the NIH budget, but that whole budgetary thing has a long ways to go, but absolutely affects us. There's been a recognition over the last, several decades that rare diseases should be studied and treated for principle. But the total budget affects it, and it depends on how competitive a grant is, and peer review ultimately is whether it gets funded or not. Now, there's also the opportunity potentially for NIH to do programs on specific in rare diseases. There's certainly recognition that rare diseases are important, but that's a policy decision on the NIH's part, I think.
No, I think, there are several aspects of the changes that have occurred. One, of course, is to do with indirect costs, which has had a huge effect on many medical centers. And I think it's not appreciated that the cost of grants doesn't just involve the direct funding of laboratory costs, but it's core facilities, all the administrative aspects of grants, which are required by the government and other agencies. Cutting those funds has had a huge effect on many, many academic institutions. So, yes, I agree that the fact that the Senate has passed some legislation is encouraging, but this is still a big issue, and I think it's very important for everybody who's concerned about medical research and scientific progress to make sure you let your representatives know your feelings about it. And certainly the rare disease community is not exempt, unfortunately, from these changes that have taken place.
Any other questions in the room?
Hi, I've got absolutely no idea who I should address this question to. I'm the mother of a 24-year-old Alpha-Mannosidosis patient from the UK. She's 21 years past BMT. She's never had any ERT. She's had a number of mental health difficulties over the last few years, and about a year ago was diagnosed by a consultant psychiatrist as having bipolar disorder, or something very similar to bipolar disorder. We have no idea, and nor, it would seem, does the psychiatrist, and nor does her metabolic doctor, of the extent to which what she's going through is related to her alpha-mannosidosis. Can anyone help at all? We do know that untreated alpha-mannosidosis patients. We have come across a couple who have suffered from psychosis, which obviously suggests that there could be a link. We're a bit clueless. Anyone any ideas?
I'll just make a brief comment. We know that in many lysosomal disorders that affect the nervous system, particularly in young adults, mimics of or psychiatric disorders are not uncommon. They're often quite difficult to treat, and that sometimes that's the way they present. So it is difficult because psychiatric illnesses are themselves rather common in the community. So dissecting out how much is the disease. Personally, I think that the underlying disorder is probably playing an important role. One point I would make it is very important to make sure that patients are treated, because even if the symptoms are a manifestation of the underlying disease, many times psychiatric treatment can be effective and, of course, makes a big difference to their outcome. But I'll ask if Dr. Isengart would like to comment.
Thank you. Yes, absolutely. There are many lysosomal diseases that are associated with psychiatric outcomes like this, and sometimes genotype can predict them. So if we think about the mucopolysaccharidoses, there's an attenuated form of MPS I with the L238Q variant that very, very often has psychiatric outcomes. So they're common in the adult population. They're also common in people who have had lengthy, sometimes traumatic medical journeys, right? Whether it's a lysosomal disease or another type of storage disease, another type of metabolic disease, or whether it's that they're survivors of cancer. But absolutely want to underscore what Dr. Patterson said, is that many times the mental health outcome needs its own separate treatment, and we don't tend to see, for some reason, and I can't say this sweepingly because we haven't entirely been equipped to study it, but the early treatment, whether it's bone marrow transplant or not, we're still seeing these psychiatric outcomes occur regardless of the initiation of therapy, and so that the treatment of the condition that comes on board is really critical.
I just want to add a short comment. Totally agree with both of you. There's a colleague in Europe coming from Slovakia who's actually trying to gather data on psychiatric manifestations in Alpha-Man. She has, I think, already 15 patients. So if you want, I could connect you. Maybe she can tell you about what she's seeing regarding therapy in those patients and so on.